everyone, and welcome again to the ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller from Johns Hopkins and consultant editor at the JOP. Many of you may be familiar with the top 5 lists that ASCO and other professional medical societies have been releasing over the past few years as part of the Choosing Wisely campaign of the American Board of Internal Medicine Foundation. The purpose of these lists is to promote conversations between physicians and patients to help patients better choose care that is truly necessary, evidence-based, and not duplicative of tests or procedures already performed. An example from ASCO's first top 5 list from 2012 was do not use PET, CT, and radionuclide bone scans in the staging of early breast cancer at low risk for metastasis, which makes sense. Well, ASCO released its second top 5 list in October 2013, and very relevant to this topic is a perspective article from the Journal of Oncology Practice that was published online in February 2014, entitled Getting from Choosing Wisely to Spending Wisely. I am pleased to have the author of that perspective, Dr. Russ Hoverman of Texas Oncology, as my guest for this podcast. Dr. Hoverman is currently Vice President for Quality Programs for Texas Oncology and Medical Director for Innovant Programs for the U.S. Oncology Network. He is a former member of the ASCO COPE Steering Committee and a current member of the Value Task Force. Russ, thank you so much for joining me this evening.
You're welcome, Bob. It's my pleasure.
Well, since everyone may not be familiar with it, can you first just give us a little background on the Choosing Wisely campaign by the American Board of Internal Medicine Foundation?
It started with the National Physicians Alliance that was supported by a grant from the American Board of Internal Medicine Foundation, and it was charged with developing and deploying activity lists of evidence-based, quality-improving, resource-sparing activities that could be incorporated into the practices of primary care providers in family medicine, internal medicine, pediatrics. This was also taken up by Howard Brody about the same time when he proposed in an article that specialty societies commit to the development of a top 5 list. This would identify 5 diagnostic tests or treatments that were commonly used but had no evidence of meaningful benefit. ASCO had a cost of care committee already in place so that we were interested in cost issues. When specialty societies were queried, we were ready in that we had an infrastructure that we could evaluate these kinds of procedures. And ASCO was one of the first specialty societies to propose 5 Choosing Wisely recommendations.
What would you say ASCO's goal was in releasing the first list in 2012 and the second in 2013?
First, I think it was to indicate that the society was interested in the overall impact of costs on healthcare. And the second was to be specific about their own practices to generate a culture of evidence within the society.
I'm going to read a quote from your article and ask you to comment. The quote is, "The mandate is to reinforce the discussions physicians have with patients and educate patients as to what is best for them based on the best science. But is it fair to ask if something more profound is occurring?" And that's the end of the quote. So the title of your article is Getting from Choosing Wisely to Spending Wisely. What is the link with value, Russ?
This is actually a very interesting time for looking at what we do in a careful way. When we think about value, we think about outcomes divided by cost, or value is directly proportional to outcomes, inversely proportional to cost. The cost is not just price. Cost may involve access, may involve loss of work time, it may involve side effects. So cost, in a way, is a patient issue, but also a societal issue. Mm-hmm. When a patient makes a decision, they're weighing relative costs. They may have the same outcome with various treatment options, but some of those outcomes may be associated with different side effects that may increase the cost for the patient. So patients will look at a recommendation in terms of its relative cost to other things. The interesting thing is that the Choosing Wisely campaign is, as I said in the article, fussy about costs and about value and about evidence, so that they're demanding, in a way, a higher level of evidence to support the use of any technology, any intervention. The other interesting thing is that I think is profound is that many of these recommendations will lead to less income for the members of their professional societies. All of the radiology recommendations were radiology procedures. The ASTRO recommendations recommended limiting certain technologies in certain circumstances. And the ASCO recommendations did the same too. Less chemotherapy at the end of life, less imaging, less testing for surveillance. Again, the evidence trumps many other factors in this situation. And that, I think, is a big change.
Now, I have heard one criticism of the campaign is that some societies conveniently overlooked procedures within their specialty that seem to impact physician incomes most directly. But it sounds like certainly for the ASTRO recommendations, that wasn't the case. Looking more globally, do you see this as a weakness of the process, or do you think we're just kind of figuring out how to pick these factors and this we sort of develop this organically?
There's a very interesting article by Morden, Colan, a group from Dartmouth that appeared in the New England Journal that addressed just that. It actually looked at the recommendations from various societies that identified some societies that made recommendations that had virtually no income effect on their own practices. That is now in the public domain, so the public can be aware of what's happening with those societies and whether they're just performing a gesture or actually really looking at evidence in a serious way. It's pretty clear that ASCO and ASTRO took this very seriously. Obviously, you want to make a recommendation that has the biggest impact. And it turns out that may also impact your own income. But if it's going to be meaningful, you want it to have some weight. And I think that is a culture change for these societies and these professions.
Now, you say that it can be very difficult to measure the impact of adherence. Why is that?
The choosing wisely recommendations were not intended to be metrics. They were intended to be supportive evidence for physician-patient discussions. And when you look at some of the first ASCO recommendations, it had to do with careful examination of the evidence of benefit for chemotherapy at the end of life. It has to do with careful examination of the evidence of benefit for growth factors in metastatic disease, for instance. These are complex discussions with many parts, and then you have to identify patients that actually qualify for that if you're going to create a metric. It's not something that is structured data, something that requires chart review, so that it's difficult. The other thing is that some of these recommendations cross databases. So, for instance, if you're going to do PET scans, you have to be identifying somebody who's getting adjuvant chemotherapy or somebody who's completed chemotherapy to get surveillance by stage. And then you have to have some record of PET scans, for instance. PET scans may be in claims data. Staging may be in your EMR, and if there's no EMR, it's in your paper chart. So you actually have to search two databases that you may not have access to. The other difficult part is that not everybody records date of death. So if you're going to do chemotherapy in the last 2 weeks of life, that may be difficult to get to.
Yeah.
So again, these are not designed to be metrics, but they are important in terms of the costs that they may save, that we should think seriously about them. They probably are more amenable to somebody who is doing, for instance, a radiation management company. Certainly gives them an evidence base to support what they think might be right. It eventually will be important to, as in our group, oncology groups that are willing to take risk to, again, support recommendations regarding utilization of tests or scans or chemotherapy or growth factors that will benefit both the patient, and the payer, as well as doing better medicine.
So would you say that these lists can be tied to performance-based payment systems? Is that happening somewhere already?
Well, there are metrics that are being tied to performance-based payment systems. COPI is being used in Michigan, for example. COPI is also being used in Virginia. With our relationship with Aetna, we have other performance-based metrics that include pathways, adherence, hospital days, some drug use patterns, for instance. So they are occurring, and whether these will be the best metrics or not remains to be seen. If you're really trying to get at the centers of cost, then hospitalization and drug use are the major ones. Mm-hmm. Imaging is important, and a number of the Choosing Wisely recommendations have to do with imaging. But again, those are separate databases, and you would have to have collaboration. But again, we will get to that, I'm sure, at some point. That may be included in the risk, or it will continue to be managed by radiology management groups.
I was just curious, are you aware of any systems that are specifically using any of the top 5 lists? I mean, I understand COPI and something that may have been around a little bit longer, but do you think this is happening somewhere in the U.S.?
Not that I know of.
Okay.
COPI obviously has a longer track record.
Yeah.
COPI itself is complicated in that there's a substantial amount of chart review involved. I do know that hospital data is being shared by large payers with providers as part of a metric.
Now, you made an interesting comment about the response of professional societies. You called it both dismaying and encouraging. What did you mean by that?
My favorite quote is from Pogo, and that is, "We have met the enemy, and he is us."
Oh, yes. I remember that.
And that's what I mean by dismaying. The fact that we've not been self-policing. And that's not really the role of professional societies to be self-policing. It should be part of group practices or institutions, but the equipment to be able to do that has been lacking. You really need to have an electronic medical record to be efficiently self-policing. I think now we're beginning to have the information systems where we can make this possible. Simply recommending a change would get nowhere if we didn't have better methods to take a look at this. Again, I think this falls back on the practices to change behavior, but that will be enhanced by incentives that reinforce that change.
Mm-hmm. Now, I think most people would agree that there's probably a limited time horizon for this kind of process because, you'd have to think that societies are going to run out of ideas of unproven and wasteful activities to kind of call out. But how do you think this process would inform the next steps for professional societies? Is this sort of along the spectrum of what ASCO is doing with the cost of care task force? And do you have any insights into any other societies that are doing similar things to kind of take it beyond simply picking 5 things every year or two?
I agree with you that there is a limited horizon for this, especially if nothing happens with the first 5, for instance. If nothing happens with the first 5 or 10, then what's the point of doing another 5? But it is a beginning in terms of a way to think. I think that payers would recognize this as a willingness to cooperate or collaborate in opening the books on both sides. Mm-hmm. That is, the physicians would be glad to share their practice patterns, their drug costs, their E&M utilization, and payers would be glad to look at hospital data, look at imaging data, look at other utilization that may impact total cost of care. And if we don't do that, we are not going to make the changes that we need to reduce waste. And again, that's the emphasis here, is that it's been suggested that 30% of overall medical costs are wasted and that there's no defined outcome that's beneficial tied to those costs. We can't get to that unless we start sharing data and developing evidence that helps us define what the right thing to do is.
So I know your article didn't really focus on the patient perspective so much, but have you heard any reactions about these top 5 lists in oncology from either individual patients or patient groups?
I haven't heard anything from patient groups. I haven't heard anything from individual patients either. I've actually heard from physicians that share the top 5 list with their patients. And there's been some comfort in knowing that, for instance, surveillance following adjuvant chemotherapy for breast cancer is not as complicated as folks would think. And there is good evidence that you don't need to have a PET scan every 6 months. I think that's where it's worked best, is that if there is a good evidence base for that discussion with patients. And again, I haven't heard any complaints from patients, but I'm sure there's still patients who insist on more than the Choosing Wisely campaign would recommend.
Well, I know I can reflect on it a little bit in my own practice, because while I don't necessarily have the discussion and tell a patient this is what ASCO says to do, because then that doesn't sound like a particularly personalized way of delivering care. I think it is nice to have this as sort of a backdrop when you're trying to explain that the example you gave about the patient who's been treated curatively for breast cancer with adjuvant therapy, and that there's not a role for serial imaging other than breast imaging and so forth. I think it's nice to have a professional society that sort of calls this out. And I think the more that this sort of process is transparent, to our customers, our patients, and the health systems, I just think that's going to be better. So I'm actually hopeful that this will get more press and not be viewed as some sort of obscure professional society directed effort that doesn't have much clinical relevance. Because I think these things on here have a lot of relevance to oncologists.
And not only relevance to oncologists, but the evidence is lacking of benefit, and that leaves open the question of whether the patient is at least as likely to be harmed.
Sure.
And that is especially true, I think, for unnecessary imaging, and that the false positive rate is not zero.
So any additional take-home messages for oncologists about this campaign and its day-to-day impact on clinical practice?
I think the take-home message is that evidence is important. Evidence counts. If we're going to do the best thing for our patients and get at costs in the way that is least objectionable to all facets of society, it will be to carefully look at what we do. And in situations where there is not evidence, consider not doing that.
Dr. Hoverman, thanks so much for being my guest and sharing your perspectives this evening.
It was my pleasure. You're quite welcome.
And thanks again to Russ Hoverman for sharing his perspectives about choosing wisely and value for oncology practice. Be sure to read the article, which was published online February 25th, 2014 at jop.ascopubs.org under early release. And thank you, as always, for downloading our podcasts. Please send your comments about these podcasts to jopeditorsdesk@asco.org. We'd love to hear from you. This is Dr. Bob Miller for the Journal of Oncology Practice. Thanks very much for listening.